Bonsoir. Alors, on va commencer avec le dernier panel de la journée, qui est le panel 2, sur pratiques de soins, discrimination et refus de soins. Nous aurons demain le panel 3. Alors, pour moi, c'est un plaisir d'être là, de voir qu'il y a des conversations tellement enrichissantes. Toute l'équipe organisatrice a beaucoup travaillé durant plus d'1 an, donc c'est gratifiant et satisfaisant de vous voir toutes et tous ici. Mon nom est Philippe Stoesslé, je suis professeur associé à l'Université de Monterrey au Mexique. Donc toutes ces thématiques, je prends beaucoup de notes parce que ça fait écho à ce que je travaille, mais dans un contexte bien différent, celui du principal couloir migratoire du monde. Et nous allons suivre en gros la même dynamique que le panel précédent. Les 3 intervenantes auront 25 minutes pour présenter leurs recherches de manière consécutive. Puis après avoir enchaîné les communications, on aura un temps pour une discussion plus générale et on voit qu'il y a beaucoup de questions du public. Alors je vais me permettre de présenter les 3 panélistes. La première d'entre elles étant Julia Eid, qui est sage-femme de formation. Elle réalise actuellement un doctorat en santé publique au Ceped, le Centre Population et Développement. Sa thèse s'inscrit dans le cadre d'une bourse CIFRE à l'association Icambere et elle porte sur l'accompagnement par le centre d'accueil de jour de cette association des femmes en situation de précarité vivant avec un diabète, une obésité ou une hypertension artérielle en Île-de-France. Notre deuxième invitée est Marianne Karlsen. She is an associate professor of the Department of Social Anthropology, University of Bergen, Norway. Her research interests include the interplay between migration control and welfare policies and the role of time in governing migration. These topics are addressed in her most recent book, Migration Control and Access to Welfare, The Precarious Inclusion of Irregular Migrants in Norway, and in the volume, Waiting and the Temporalities of Irregular Migration, that she co-edited with Sharam Khosravi and Christine Jacobsen. Currently, she leads the research project Contested Knowledges in and Through Asylum Litigation, funded through an ERC, European Research Council, starting grant. Et finalement, nous avons Nina Sahraoui, qui est responsable, Principal Investigator, d'un autre projet ERC, Gender Climate MIG, mené au laboratoire Printemps du CNRS. Ses travaux portent sur l'articulation entre les questions migratoires et les questions de genre. L'ouvrage issu de ses recherches doctorales a été publié chez Palgrave Macmillan sous le titre « Racialized Care Workers and European Older Age Care, From Care Labor to Care Ethics » en 2019. Ses publications récentes incluent les ouvrages « Border Across Healthcare » chez Bergen Books en 2020, « Gender-Based Violence in Migration, Interdisciplinary Feminist and Intersectional Approaches » chez Palgrave aussi en 2022, et Post-Coloniality and Forced Migration chez Bristol University Press en 2022. Ces recherches ont également été publiées dans les revues Raison politique, Migration et Société, Journal of Ethnic and Migration Studies, Society and Space et Social Policy and Society, entre autres. Donc merci pour votre présence et j'invite Julia Eid à prendre la parole.
Déjà, je tiens à remercier l'équipe de m'avoir proposé d'intervenir dans ce colloque. Donc, ce que je vais vous présenter, c'est une partie de la recherche que je mène dans le cadre de ma thèse, que je réalise sous la direction d'Annabelle Desgrès-du-Loup à l'association Icambere. Donc, la présentation s'intitule « Femmes migrantes en situation de précarité, vivant avec un diabète, une obésité ou une hypertension artérielle, comment les accompagner vers une meilleure alimentation ?» Donc déjà, je vais commencer par rappeler quelques chiffres sur ces maladies chroniques. C'est des chiffres issus de grandes enquêtes de Santé publique France. Donc en France, l'hypertension artérielle concerne 30% des adultes, l'obésité concerne 17% des adultes et 5% de la population vit avec un diabète. Les maladies cardiovasculaires sont la principale cause de mortalité chez les femmes et touchent particulièrement les plus défavorisées. Une enquête de l'Observatoire national de la politique de la ville a montré que 54% des femmes qui résidaient dans un quartier prioritaire sont en surpoids, contre 38% dans les autres quartiers. Et le diabète est 1,7 fois plus élevé chez les femmes des communes les plus défavorisées. Concernant la prise en charge de ces pathologies, c'est une prise en charge on peut dire que cette prise en charge est cloisonnée entre différents acteurs et types de structures, au niveau des structures médicales, des structures médico-sociales. C'est une prise en charge qui est souvent limitée à une prise en charge médicale et thérapeutique, alors qu'elle passe aussi et surtout par un accompagnement à l'évolution des comportements de santé, comme l'alimentation, l'activité physique ou la consommation d'alcool et de tabac. Et cette prise en charge, elle est souvent difficile dans les populations les plus défavorisées, en raison de leurs conditions de vie qui sont généralement instables et précaires, leur manque de ressources qui est souvent associé à une situation d'insécurité alimentaire, et en raison d'autres barrières comme la barrière de la langue pour les populations immigrées. Donc on peut se demander quel type d'accompagnement serait le plus adapté pour les femmes en situation de précarité, et d'autant plus pour les femmes immigrées qui vivent avec ces pathologies. Donc ce que je vais vous présenter maintenant, c'est un exemple d'accompagnement qui est proposé à des femmes en situation de précarité, qui vivent avec l'obésité, le diabète ou l'hypertension artérielle. C'est l'expérimentation menée par l'association Icambéré, qui a ouvert il y a 1 an et demi un centre d'accueil de jour et d'accompagnement, la maison Igikali, pour ces femmes en Île-de-France. Et il se trouve que la majorité de ces femmes, pour ne pas dire toutes, sont des femmes immigrées. Donc le centre propose un accompagnement global et inconditionnel, c'est-à-dire sans conditions administratives ou territoriales, comme ça peut l'être dans certaines structures, et toutes les activités sont gratuites. Il y a une équipe pluridisciplinaire qui est composée d'une médiatrice en santé, d'une assistante sociale, d'une diététicienne, une cuisinière, un coach sportif, qui accueille et qui accompagne toutes les femmes quotidiennement. Donc c'est un centre qui est ouvert en semaine uniquement et en journée. Cette structure, elle travaille également en étroite collaboration avec le secteur médical, donc les hôpitaux, les centres de santé, les réseaux de santé, les institutions comme l'ARS, l'Agence régionale de santé, ou bien la commune d'Ivry sur laquelle le centre est implanté. Elle travaille également avec les associations et les maisons de quartier qui ont une connaissance fine de la population et du territoire, et puis avec les centres d'hébergement comme ceux gérés par le SAMU social de Paris. Donc l'accompagnement qui est proposé à la maison Igikali, c'est un accompagnement qui est à la fois individuel et collectif et qui s'articule autour de 3 axes. L'accompagnement autour de la santé, l'accompagnement social et l'accompagnement vers l'emploi. En ce qui concerne l'accompagnement à la santé, qui est l'axe majeur de la maison Igikali, il y a différentes thématiques qui sont abordées. Déjà au niveau de l'alimentation, il y a quotidiennement des repas faits maison qui sont préparés et partagés entre les femmes et avec l'équipe de l'association. Il y a des ateliers diététiques qui sont organisés, des ateliers à la fois théoriques et puis des ateliers cuisine, et des entretiens avec une diététicienne. Il y a aussi une multitude d'activités, de séances d'éducation thérapeutique du patient, où là on s'intéresse plus au fonctionnement des pathologies, à leurs complications et puis à l'observance des traitements. Il y a des activités physiques, de l'activité physique adaptée, du yoga, de la danse, de la marche qui sont organisées chaque semaine. Et puis d'autres activités autour du bien-être, comme la socio-esthétique, et puis d'autres activités manuelles, des sorties culturelles, etc. Au niveau de l'axe social, il y a un accompagnement social qui est réalisé par une assistante sociale. Comme la majorité des femmes sont immigrées, il y a un travail qui est fait sur l'accès aux droits et aux titres de séjour. Et puis ponctuellement, l'association octroie des aides matérielles et financières dans les situations d'urgence. En ce qui concerne l'emploi, il y a des ateliers d'insertion professionnelle, donc de préparation de CV. Il y a aussi des ateliers informatiques et puis des cours de français. Donc ce qui nous intéresse aujourd'hui, c'est l'accompagnement à l'alimentation. L'objectif de l'étude, c'est d'évaluer l'accompagnement à l'alimentation. Un objectif spécifique est de comprendre les mécanismes et les facteurs contextuels qui conduisent ou non à des changements de l'alimentation. Et le deuxième objectif, c'est d'identifier les clés de l'intervention qui permettront de dupliquer ce type d'accompagnement à d'autres contextes et à d'autres territoires. En termes de méthode, on a adopté une approche qualitative avec des entretiens semi-directifs avec les femmes, accompagnées par le centre, et des observations participantes au centre Igikali. Donc à la fois la vie quotidienne du centre, les activités collectives, les entretiens individuels. Toujours en termes de méthode, on a utilisé une évaluation réaliste. C'est une méthode qui a été développée par Karlsen et Tillet en 1997. L'objectif de cette méthode, c'est de répondre aux questions qu'est-ce qui fonctionne ou non dans l'intervention, pour qui ça fonctionne ou pas, dans quelles circonstances, pourquoi et comment. Donc en fait, le principe de l'évaluation réaliste, c'est que les individus soumis à une intervention vont avoir des réactions qui vont conduire à des effets. Donc en fait, les réactions des individus sont les mécanismes qui eux-mêmes sont fortement influencés par le contexte. Donc voilà comment se présentent les résultats d'une évaluation réaliste. Et enfin, concernant la méthode, cette recherche, elle s'inscrit dans le courant de la recherche communautaire. En effet, déjà, l'intervention qui est évaluée, elle a été vraiment pensée et mise en œuvre par l'association. Et puis, du fait de mon statut à la fois de chercheuse et de salariée au sein de l'association Icambéré, j'ai en fait une grande proximité avec le terrain, ce qui permet aussi une co-construction de la recherche avec l'équipe de l'association. Donc voici les résultats. Donc on a réalisé 12 entretiens avec les femmes accompagnées par le centre depuis plusieurs mois. Ces femmes sont en situation d'instabilité résidentielle et administrative. Donc la majorité sont dans des situations instables au niveau de l'hébergement. Elles sont soit hébergées par le sommeil social, soit hébergées par un tiers pour la moitié d'entre elles. Elles ont un accès assez difficile à une cuisine, voire une absence totale de cuisine sur leur lieu de vie pour presque la moitié d'entre elles. La majorité est en situation irrégulière et elles sont toutes immigrées, majoritairement d'Afrique subsaharienne et 2 d'entre elles d'un pays d'Afrique du Nord. C'est des patientes polypathologiques. Presque la moitié d'entre elles sont concernées par au moins 2 des 3 pathologies qui nous intéressent. Mais par contre, elles ont toutes une couverture maladie et elles ont toutes un suivi par un médecin. Donc voilà les résultats. Donc sous la forme intervention, mécanisme, effet et puis les éléments de contexte qui influencent. Donc ce qu'on a pu mettre en évidence, c'est que l'accompagnement à l'alimentation, il a permis de déclencher des mécanismes d'empowerment individuel chez les femmes qui ont permis la production de différents types d'effets, à la fois des changements cognitifs et des changements comportementaux, qui forment en fait un continuum qui va de la prise de conscience de ses propres comportements alimentaires et de l'importance de l'alimentation pour la gestion de la maladie, vers l'initiation d'un changement de l'alimentation jusqu'à des modifications importantes de l'alimentation. Et on a identifié des éléments de contexte qui influencent à la fois la production de mécanismes et à la fois la production des effets. Donc je vais rentrer un peu plus en détail pour chacun des effets différents. Donc pour les femmes chez qui on a observé des modifications importantes de l'alimentation, donc c'est le schéma qui est là, je vais commencer par vous détailler l'intervention. Donc, ce qu'on a pu mettre en évidence comme élément important de l'intervention, c'est que les ateliers, l'accompagnement autour de l'alimentation a lieu dans un lieu dédié, qui est la cuisine cafétéria. Donc, c'est le lieu où on prépare les repas, où les femmes se retrouvent entre elles aussi. Ça, c'est le premier élément. Le deuxième élément, c'est le fait qu'il y ait des repas faits maison qui sont offerts et partagés tous les midis, à la fois entre les femmes et puis avec l'équipe de l'association. Donc, ce sont des repas équilibrés qui permettent aux femmes de découvrir des nouvelles saveurs, des nouvelles techniques de cuisine. Autre point, donc ce sont les ateliers cuisine, à la fois pratiques et théoriques. C'est des moments où les femmes se retrouvent en collectif, c'est un espace de sociabilisation. C'est un moment convivial pour les femmes. Les ateliers font vraiment référence aux habitudes et aux pratiques alimentaires des femmes. C'est des ateliers qui sont aussi développés en s'adaptant aux conditions de vie des femmes et puis aussi à leur niveau de littératie. Et puis c'est des moments où la diététicienne apporte des connaissances à la fois théoriques et pratiques qui permettent aux femmes d'expérimenter, de connaître d'autres techniques de cuisine, de découvrir des aliments, etc. Et c'est des ateliers qui ont lieu au moins 2 fois par semaine. Voilà, il y a aussi des semaines thématiques qui sont organisées, des animations lors des repas. Autre élément, ce sont les fiches recettes. Donc, c'est les outils développés par la diététicienne qui sont utilisés lors des cours de cuisine et que les femmes peuvent aussi remporter chez elles. Et enfin, l'accompagnement individuel avec la diététicienne, où là, c'est en général des consultations qui sont assez longues, qui peuvent durer plus d'1 heure et puis qui sont répétées dans le temps. Donc ce qu'on a mis en évidence, c'est que cette intervention, elle a permis de déclencher plusieurs mécanismes. Donc le fait d'acquérir des connaissances et des compétences, le fait de faire l'expérience de manger équilibré et puis de constater qu'on se sent bien après le repas et dans la journée, faire l'expérience de ne pas grignoter pendant la journée aussi. Autre mécanisme qui est la fidélisation, le fait de participer régulièrement aux séances et puis de s'approprier les lieux. On a identifié aussi que les femmes utilisaient les fiches recettes chez elles, à la fois pour cuisiner différemment, mais aussi pour transmettre et apprendre aux personnes avec qui elles vivent voilà, ce qu'elles apprennent au centre. Ce qu'on a identifié aussi, c'est que cet accompagnement à l'alimentation permettait une rupture de l'isolement. Les femmes, elles partent souvent de la maison Igikali comme déjà d'une maison. Elles ont l'impression d'être en famille quand elles viennent. Voilà, donc elles se sentent aussi utiles en cuisine, ça renforce leur confiance en elles, leur estime d'elles-mêmes, etc. Et puis enfin, le fait d'avoir le temps d'échanger et d'entendre les messages de prévention qui sont répétés plusieurs fois, la répétition qui est un mécanisme assez important. Donc ce qu'on a pu mettre en évidence en termes d'effets, c'est dans un premier temps, donc pour ces groupes de femmes, c'est une prise de conscience et une modification importante du régime alimentaire. Et ce qu'on voit, on a pu identifier des caractéristiques communes à ces femmes. Ce sont des femmes qui ont des ressources financières, ce sont des femmes qui ont accès à une cuisine sur leur lieu de vie. C'est des femmes qui, également, dans leur antécédent de santé, ont connu un événement grave de santé, comme un cancer, la découverte d'un VIH ou des complications graves du diabète. Et puis, c'est des femmes qui ont réussi à adopter de nouvelles habitudes, à quitter certaines pratiques culinaires qu'elles avaient. Donc, je passe au groupe de femmes pour lequel il y a eu uniquement des modifications de l'alimentation qui restent à la marge. Pour ces groupes de femmes, ce qu'on a pu identifier comme caractéristique, c'est qu'elles avaient des ressources financières, mais qu'elles étaient limitées, qui ne leur permettaient pas d'acheter des denrées alimentaires choisies réellement, c'est-à-dire des fruits, des légumes, de la viande, qui sont en général coûteuses. C'est là aussi des femmes, comme précédemment, qui ont accès à une cuisine sur leur lieu de vie et qui ont cet antécédent grave de santé dans leur histoire. Par contre, c'est des femmes qui, là, ont toujours ces pratiques alimentaires qui ne sont pas en accord avec leur pathologie, comme par exemple l'utilisation de bouillon cube dans la cuisine d'Afrique de l'Ouest. C'est assez commun, sauf que c'est excessivement salé. Et voilà, c'est un exemple d'habitude que certaines femmes n'arrivent pas à quitter. Et on a identifié également que c'était des femmes qui vivaient en cohabitation. La cohabitation est aussi un frein au changement du régime alimentaire. Enfin, dernier groupe de femmes pour lequel il y a eu uniquement une prise de conscience. Voilà, c'est des femmes qui ont pris conscience de leur alimentation, des problématiques, de l'importance de l'alimentation pour la maladie, qui sont motivées pour changer. Mais ces femmes, ce qu'on a pu constater, c'est que pour certaines d'entre elles, il y a des mécanismes qui n'opéraient pas, comme la fidélisation ou le fait d'entendre les messages régulièrement, donc la répétition. Sont des femmes qui, en effet, viennent un peu moins souvent au centre. Soit elles ont une activité professionnelle, souvent un travail non déclaré, soit ce sont des femmes qui manquent de ressources financières pour acheter des titres de transport, qui de fait viennent un peu moins souvent au centre. Et ce qu'on a également pu constater chez ces femmes, c'est qu'il y a une absence de cuisine, voire ou un accès très limité à la cuisine sur leur lieu de vie. C'est des femmes qui vivent en cohabitation et qui manquent de ressources, voire qui n'ont aucune ressource financière pour acheter à manger. Voilà, donc ici, je vais vous présenter les éléments de l'intervention en lien avec les mécanismes qu'on a pu identifier. Donc ce qu'on a vu, ce que j'ai dit au début, c'est que ce sont des mécanismes d'empowerment individuels. Donc au niveau du renforcement des connaissances, ce qu'on a vu au niveau de l'intervention, c'est que ce qui était important, c'était d'apporter des connaissances régulièrement, donc la répétition, le fait de développer une communication et des outils qui étaient vraiment adaptés à la population en termes de littératie, mais aussi en termes de compétences, de ressources et d'habitudes des femmes. Donc autre mécanisme, le renforcement des compétences. Donc là, ça passe par donner l'occasion aux femmes de cuisiner régulièrement, Pour renforcer la participation, ça passe par donner aux femmes l'occasion de faire l'expérience de manger régulièrement, équilibré, des repas faits maison, quotidiens et puis gratuits. Le renforcement de l'estime de soi, ça passe par le fait que cet accompagnement il ait lieu dans un endroit vraiment dédié, avec un rendez-vous dédié. Le fait d'associer un temps de bien-être à ces ateliers et aussi d'offrir un espace de parole individuel. Et enfin, le renforcement de la conscience critique, qui est favorisé par la paire aidance, le sentiment d'appartenance au groupe et puis l'accompagnement sur le temps long. Et je finirai par quelques limites de la recherche. Donc déjà, le fait qu'on évalue une expérimentation, le centre a ouvert depuis 1 an et demi, donc on a assez peu de recul pour évaluer la durabilité de ces changements. Une deuxième limite de cette étude, c'est que c'est une analyse qui porte sur une partie restreinte d'un accompagnement plus global que je vous ai présenté précédemment. Au niveau de l'intervention, on étudie uniquement l'accompagnement à l'alimentation et les changements au niveau des comportements alimentaires. Or, on sait que les comportements alimentaires sont multifactoriels et qu'il y a un rôle, par exemple, important de la santé mentale. Donc ce sera intéressant, dans un second temps, d'analyser l'accompagnement dans son entièreté. Et puis enfin, en tant que chercheuse, j'ai surtout été identifiée comme un membre de l'équipe de l'association par les femmes, ce qui crée du coup un biais de désirabilité. Enfin, je crois que cette étude a permis d'identifier les éléments qui sont pertinents à prendre en compte pour la réplication de ce type d'accompagnement à d'autres contextes, à d'autres populations. Et cette recherche aura une utilité forte à la fois pour le développement de l'association et d'ajustement de l'intervention, mais aussi pour les politiques publiques et l'évaluation des politiques publiques. Je vais m'arrêter là. Merci.
You. Can you hear me all right now? Yes? Well, I would also like to thank the organizers for inviting me. It's been really interesting to listen to the different presentations and also think of the similarities and also the differences between different contexts. I've been working mainly in Norway, which is from where I will present in this. So, as we also mentioned earlier in the presentation, research have explored healthcare and welfare policies as internal bordering practices. Control of migrants' mobility is not only constituted at the territorial outer edge of the state, but also dispersed within states' borders. However, what I will suggest in this presentation is that these internal bordering practices do not only have spatial implications, but also temporal ones. So in the presentation, I want to address how the temporal lens of migration control frame the medical gaze and hence the medical care offered to so-called irregular migrants in Norway. Like many other European countries, Norway has, as part of the turn towards internal border control, implemented measures that limit irregular migrants' access to healthcare. My suggestion here is that the internal border control in the context of healthcare in Norway is not simply about excluding migrants at the hospital doorstep, but importantly draws the territorial and temporal rationality of migration control into the Diagnostic Act itself in terms of deciding the course of treatment. To elaborate my argument, I will present a case that I followed over several years during my fieldwork. But first, some context of the research that I have conducted. So, this presentation draws on research that I have conducted as part of two larger research projects. The main part of the research was conducted between 2011 and 2013 as part of the PROVIR research project, that is, Provision of Welfare to Irregular Migrants. This was a collaboration between anthropologists and legal scholars and only looked at Norway. This research was also followed up by the WAIT project, that is, Waiting for an Uncertain Future, the Temporalities of Irregular Migration, where I did fieldwork between 2017 and 2018. The aim of this project was to use temporality as an analytical lens to examine power relations and experiences in irregular migration. In the course of these two research project, I conducted ethnographic fieldwork in Oslo and Bergen, the two largest cities in Norway. And part of this fieldwork consisted of spending time at a healthcare center for undocumented migrants in Oslo. When I started my research project, there was only a healthcare center in Oslo, but I also followed attempts at starting one in Bergen, and now there is also one in Bergen. I also did interviews and conversation with about 50 healthcare providers at different parts of the Norwegian healthcare systems, and also with different NGOs. But I also spent a lot of time following irregular migrants over time. Follow them in the sense of having multiple conversations with them, as well as accompanying them in their various daily activities, and also accompanying them to medical appointments. I should mention that when we talk of irregular or undocumented migrants in Norway, the discussion is mainly about so-called rejected asylum seekers. There is not much discussions about irregular migrants being a significant part of the workforce, as has been mentioned in other cases. It's very much treated as a case, as part of the asylum system. And also in Norway, it is possible for rejected asylum seekers to live in state reception centers, also after their application is rejected. So the numbers are not necessarily high, although they are very uncertain. But many of those that I did my research with lived for very, very many years in Norway. In the second fieldwork, for the WAIT project, I spent time with an organization called Humans in Limbo. And most of them that I spent time with there were women who had lived in Norway for between 10 and 20 years as undocumented migrants. They were mainly from Ethiopia and Eritrea. But in the overall project, they were from many different contexts than men and women, but this was the main group for the second part of the project. So the case I will present today is the case of Hind. Hind was a young primary school girl whom I met during the early stage of my fieldwork and who was in need of extensive surgery. Children left untreated could survive into adulthood, but morbidity is severe and the condition poses significant physical, functional, social, and psychological burdens on patients and families. It was also a condition that was challenging for healthcare providers and would, in normal circumstances, be treated with surgery from a very early age, with lifelong follow-up care. However, upon learning that Hind and her family's asylum application had been rejected, the surgeon was not willing to go through with complicated procedures. About a year after I met her, Hind's condition started to worsen. She complained of pain making it difficult for the parents to carry out the daily care necessary to keep her condition under control. Not able to help, the local doctors kept pushing the surgeon to see her again. After several attempts and months, Dr. Johan, the surgeon, finally agreed to see her. Over the years that I follow Hind and her family, Dr. Johan had grown to become the villain in this story, and the parents directed a lot of their anger of being rejected both by the immigration authorities and by the hospital at him. As the parents saw it, he was the main obstacle to both Hind's medical treatment and to the residents' aspirations. Dr. Johan, however, when I finally met him, was clearly uncomfortable with being the villain. In the medical appointment with Hind's parents, he tried to explain that it was not that he did not want to help them. His main dilemma, as he laid it out, was that the best medical option for Hind varied, depending on whether she would be deported or allowed to stay. If he performed the same surgery as he would for legal residents, and Hind was deported and left without proper medical follow-up, her situation could become fatal. Dr. Johan could perform another type of surgery that would be less risky in case of deportation, but would have less satisfactory result in terms of life quality for Hind, and could entail more rounds of surgery to rectify this if she was ultimately allowed to stay. For Dr. Johan, this was a difficult medical decision, and he and the hospital initially decided not to do anything, as they believed that Hind would shortly leave the country, having received the so-called final decision. Years later, with no change in Hind's legal situation, still rejected but not deported, and with her health situation worsening, the doctors decided that they had to do something. In the end, the hospital decided to go for the medically less optimal, but possibly safer surgical option in case of deportation. Shortly after surgery, though, Hind was granted residency. This was not due to her medical condition, but part of a general softening of policy towards so-called long-staying asylum children. However, residency for Hind also meant new rounds of surgery to get the more optimal medical solution. I would suggest that Hind's case illustrates the many ways in which the territorial and temporal rationality of migration control is drawn into the medical decision. First and foremost, it illustrates how the general condition of deportability, that is, the constant possibility of deportation rather than deportation per se, creates practical and ethical dilemmas for healthcare providers. Healthcare always has a forward-looking dimension in terms of prognosis and treatment plans. Medical practice thus relies in parts on doctors' control of patients' time and space. In Hind's case, the unpredictability that permeates the threat of deportation had a disciplinary effect on the healthcare providers. It made them reluctant to initiate surgery, and therefore to treatment initially being delayed or deferred. The case also illustrates how Hind's continued presence became not only a headache for the immigration authorities, but also for the healthcare system. As time passed, it became more difficult for the doctors to justify the lack of treatment, and eventually the doctors performed surgery even though her situation had not become more predictable. The case, I suggest, therefore indicates an inherent tension between the temporality of medicine and the temporality of migration control. Hind, with her complicated somatic condition, represent in many ways a distinct case where the tension between the temporalities of medicine and migration control intensifies. In most cases, the healthcare providers in my studies stressed that the problems they encounter could be dealt with at the primary healthcare level. Still, many of the same dilemmas appeared, particularly the difficulties of providing continuity of care due to the possibility of patients suddenly disappearing and or the limited or lack of means for contacting them. In my fieldwork, I observed how the temporal insecurity inscribed into the medical encounter by these bodies being deportable led to hesitation and deferred treatment, as in Hind's case. However, it could also lead to interrupted treatment and to what the healthcare providers in my study described as an orientation of medical practice to the here and now perspective. This means trying to address whatever health problem within the allotted time of the medical appointment. As such, it was oriented to the urgency of the present, offering temporary solution rather than fully curing or caring for the patient. I should also mention that it was not only doctors' hesitation that led to deferred treatment. I also observed how irregular migrants were deterred from accessing healthcare. Many experienced their encounters with healthcare providers as uncomfortable and risky. This was partly because of the practice of being routinely asked for ID and personal identification numbers, but also because they were expected to pay the full cost of medical care, even when they have an explicit right to the health care. Or actually, the law states that it is that if the patient cannot cover the expenses, costs should be covered by the healthcare institutions. However, as these institutions are not reimbursed by the state, they have to cover it through their budget. But the practice that has been developed is that they increasingly aggressively pursue the patients for this payment. So they cannot ask for prepayment, but they keep issuing quite high bills after treatment, and people are confronted with their bill when they seek treatment again. So this becomes part of an environment of suspicion and mistrust that discourage irregular migrants from approaching healthcare services. And this may have grave consequences. When we did this research, this was of course things people were telling us, but a recent PhD project that is conducted by Frode Eik, which was, when I was doing my research, was the director of the volunteer-run healthcare center, and now he's doing his PhD. And he has showed some of the consequences, or in his research indicates some of the potential consequences for pregnant undocumented migrants of this environment of suspicion. Pregnant undocumented migrants in Norway have the right for prenatal care in municipalities and for giving birth at hospital. However, Frode's study, which is a study of several hundred medical records, which he has been able to identify, shows that twice as many undocumented pregnant women are severely ill when they seek help. Also, many seek too late help to receive prenatal care, and there is a high occurrence of emergency C-sections, babies being born too early and stillborn among pregnant undocumented women in Norway. So, the temporal dilemmas for healthcare providers raised here is, as mentioned, caused by in main part by the general condition of deportability. However, in the Norwegian case, it is also reinforced by a healthcare regulation introduced in 2011. Since 2004, it has been an official aim in Norway that all contact between public institutions and the individual irregularized migrant should signal a sense of temporariness as to indicate that their time in Norway has come to an end. The healthcare regulation is a prime example of this. The Norwegian Healthcare Act uses the phrase everyone residing in the realm when defining the scope of the law. As such, the law does not distinguish between legal statuses, and this has been the law since the 1990s. However, in 2011, Norway introduced a new healthcare regulation, and this is an administrative reinterpretation of existing laws that made it explicit that irregular migrants were excluded from an initially inclusive entitlement. So this was not something that was debated by Parliament. It was done on an administrative level, but which severely restricted irregular migrants' access to health. But the regulation do also specify some entitlement that irregular migrants have. They have, in addition to emergency care, right to health care that cannot wait without dangers of imminent death, permanent and seriously reduced functionality, serious injury, or severe pain. Children, pregnant women, prisoners, and persons with communicable diseases were also granted some additional rights. But I will be focusing on this notion of healthcare that cannot wait. This was meant to expand access to healthcare beyond emergency care. However, the notion is difficult for healthcare providers to interpret, as it establishes a new and poorly defined priority level in the Norwegian healthcare system based on unfamiliar temporal considerations. In the background documents and guidelines, the ministry indicate that treatment that can wait 2 to 3 weeks should not be initiated. This time frame was not medically justified, but was set according to what the Ministry of Health considered to be a reasonable time frame for irregular migrants to be able to leave the country. How the ministry decided on this time frame is not possible to identify, and for, I think, most people who have worked in the field, it doesn't seem like a reasonable time frame. But this is what they have set, and they created this table that shows example of condition that could fall under the scope of the concept healthcare that cannot wait. However, this has been very heavily critiqued, and I don't know to what extent healthcare providers actually look at this. But the main point of the law, although this is an example and it's meant as to indicate, the law makes the evaluation of what condition cannot wait. This decision is delegated wholly to the doctors to make in each individual case. So it defers to the doctor's decision to make this. And the healthcare providers that I interviewed found the term, as I said, difficult to interpret, as these quotes illustrates. The doctors did not see the time frame of 2 to 3 weeks suggested by the ministry as a workable guideline for deciding whether or not to initiate treatment. The regulation says nothing about the realism of the departure or whether or how doctors should know if treatment actually would be available to the patient within this time span. Having to assess the acuteness of treatment without having this information was regarded as putting the doctors in an impossible situation. A main challenge for healthcare providers became how to treat chronic patients and patients with conditions that would worsen over time. For example, it was not cancer itself, but suspicions of very serious cancer and cancer in the terminal stage that triggered the right to healthcare. From medical viewpoint, this contradicts established practice and knowledge that indicate that untreated illness and treatment prospect often worsen over time. And as also been mentioned here previously, healthcare could potentially come at a greater economic cost than if the patient had received adequate treatment at an earlier stage. And And in regard to this, we do start to see example of this having consequences. In Bergen last year, a publicized case was a case of a man who sought treatment at the healthcare center for undocumented migrants, but were refused treatment at hospital until his condition became acute. Then he was given treatment, but by then it was too late and the man died. So we start, the healthcare center also in Oslo have example of how this healthcare that cannot wait has led to situations where treatment is given at a too late stage. I also can mention that here it's interesting to note that the Swedish legislation, which also uses the phrase healthcare that cannot wait, but defines the same term completely differently. In Sweden, healthcare is given to irregular migrants if it can counteract a more serious illness or supplant the need for more comprehensive care and treatment. Hence, in Sweden, continuous treatment of chronic condition can be interpreted as healthcare that cannot wait, but this does not hold true in Norway. This underscores again how the term in the Norwegian case is ultimately about establishing a medical standard based on the temporal rationality of migration control, that is to produce a sense of temporariness to signal that the migrant's time in the country is up. I should also briefly mention that, let me see, just skip some, yeah. Children up to the age of 18 have more extensive rights to healthcare than adults. However, also for children, temporariness is evoked in the healthcare regulation through the sentence, unless concern for the child dictate that assistance should not be provided. And when is that? This sentence does not refer to the best interest of the child in line with the UN Convention on the Rights of the Child, but instead stipulated that treatment should not interfere with the state's attempt to deport the child. In the case of children, neither the regulation nor the consultation paper or the guideline indicates a reasonable time frame for deportation to occur, and it is unclear whether doctors should consider a theoretical frame for a possible departure, or they should try to establish a realistic time frame, which doctors weren't really interested in doing. This is another case that received media attention at the same time as I was following Hind. Adam was a 9-year-old boy, and as with Hind, was in need of extensive surgery that he was initially denied. However, as this case received media attention, the Minister of Health actually did go out and say that the law did not prevent doctors from treating children in Adam's and also in his case, because it was ultimately the doctor's decision. So, to sum up, I suggest that the healthcare regulation, well, as I've shown, the healthcare regulation does not forbid the treatment of irregular migrants, but establishes the person with legal residency as the norm and thus legal status as a criterion for judgment. As such, the healthcare regulation delegates the responsibility to decide whether treatment should be given or not based on migration concerns and not just medical reasons. By devolving responsibility for the decision to exclude to professional discretion, the Norwegian government has depoliticized the sensitive question of irregular migrants and particular children's right to healthcare. Furthermore, I suggest it imposes a particular temporal frame on medical assessments and treatments. Combined with the general condition of deportability, urgent and deferred treatment becomes the norm. Thank you.
Et nous terminons avec Nina Sahraoui.
Merci. Bonjour à toutes et à tous. Hello everyone. Thank you very much for the invitation to present today. I'm really grateful for this opportunity to share my research with you, and I look forward to the discussion. I will have to stick to my notes. I'm really sorry, but otherwise you're going to have to listen to me for 1 hour, and I think that's not the deal with the other panelists and with Stefan, so I will have to stick a bit to my notes. So today I will be presenting research that I have conducted in the framework of the EU Border Care Project in 2017 with Comorian women's access to maternity care in Mayotte. So you can see here a map of where Mayotte is. It's a French overseas department. And I'll focus on the specific setting of what the midwives there were calling the Kwassa consultations. This name of the Kwassa consultations comes from the name of the small fishing boats that are used to cross from the Comorian Islands to Mayotte, because they're called the Kwassa boats. And during these consultations, the midwives have to assess whether the health situation of pregnant women who are arrested at sea by the border police is compatible or not with detention. But maybe I need first to start with a few words of context. So Mayotte was sold to France in 1841, and it was administered from the colonial center of Madagascar before being then grouped with the 3 other Comorian islands of Grande Comore, Moélie, and Anjouan in their French denomination. And the struggle for independence of the Comorian Islands led to the French state to organize a referendum in 1974 in which a majority of voters supported the island's independence, except on the island of Mayotte. So France organized a second referendum in Mayotte in 1976, and this is how Mayotte remained under French administration and sovereignty. And in fact, Mahoran elites actively fought for the island's integration into the French compound since the 1950s, but the Union of the Comoros continues to claim its sovereignty over the island. And now, jumping to recent history, Mayotte formally became a French overseas department in 2011. But we have still a series of kind of dedicated legislations, legal exceptions, that concern labor market regulation, social services, migration governance, of course, that kind of still perpetuate a state of marginalization and exteriority. Mayotte is often portrayed as constantly facing unmanageable flows of migrants from these neighboring islands of the Comoros, and notably the closest one, Anjouan. And as a matter of fact, to mention a couple of figures, 48% of the island's inhabitants fall into the category of foreigners, and about half are estimated to be undocumented. The overwhelming majority are from the Comoros, 95%. But the strikingly high rates of undocumented persons who reside on the island result also from the implementation of a repressive migration regime across post-colonial borders that is exacerbated by a derogatory administrative management of migration at the local level, and this includes additional requirements for regularization compared to mainland France. So I explored this in a different article drawing on life stories with Comorian women that shows that many of these women have been on the island for a very long time without any possibility for regularization. And in Mayotte, restrictive migration management leads to the forceful deportation of about 1/10 of the island's inhabitants each year. And those being forcibly deported are likely to embark again on one of the small boats, as you can see here on the slide, the ones that are called the Kwassa boats, and they are then also likely to take greater risks the more the border is securitized, in brackets, by crossing at night or in bad weather to avoid being intercepted. And when they are intercepted at sea, the overwhelming majority of detained persons are deported back to the closest island, to Anjouan, within a few hours because of a specific legislative disposition that shape Mayotte's migration regime. So it's very different from being detained in a detention center in mainland France, so to say. Some of those persons who are intercepted at sea by the border police are able to see a doctor before being detained, and this is usually the case for pregnant women. provided that their conditions is known to the police. And these women are brought to a small maternity center where these quasi-consultations take place. And here I'd like to quote a midwife who had to conduct such consultations. And she says, "Since there's no legislation, no protocol, the decision is really up to us." So referring to this decision whether the health state of a pregnant woman is compatible or not with detention. In fact, there's something that bothers me deeply about this. It's that I feel like I risk my diploma. Each time I see a quasa, so now she refers to a woman who has just been intercepted by the police on one of these boats, I think about it all day. And sometimes in the evenings, I still think about it. And it stresses me out because I feel like I risk my diploma. Last time I had a twin pregnancy at 31 weeks with a long cervix that didn't contract, I sent her back. But all day I was thinking, and if something, is that too loud? Sorry, I hear myself around, but no. No, it's okay. But all day I was thinking, and if something happens at the detention center, what if she goes into labor? What if there's a problem? So in this quote, this young midwife from metropolitan France shared her doubts about her decision to send back, as she says, a woman with a twin pregnancy. And sending back in this context means that the midwife signs a medical certificate attesting to the patient's health state as compatible with detention. And as a result, the pregnant woman is accompanied by policemen to the detention center and then most probably forcibly removed to the Union of the Comoros in the hours that follow. When the health situation of a woman is not deemed compatible with detention, she is either immediately hospitalized or prescribed a specific treatment to be monitored by the hospital or a local health center, and as a consequence, she's staying in Mayotte as an undocumented person. So midwives are not physically intervening inside the detention center, but they play a role in the local management of migration and in the steps leading up to deportation. So in the paper upon which I draw my presentation today, I explore the ambiguities of this healthcare migration nexus in this specific setting. And today I want to focus on how midwives navigate the ethical dilemmas that are raised by their involvement in migration control. And I argue in the paper that midwives' practices undergo socialization, so to say, by the repressive migration regime that engender very problematic entanglements between healthcare and migration control. A few words about the methodology. So it's an entirely qualitative study. It draws on a 3-month ethnographic fieldwork that I conducted in different hospital sites on the island of Mayotte in 2017. And I carried out this research in the framework of the EU Border Care project, as I mentioned. And this fieldwork entailed interviews with midwives and healthcare assistants. And overall, I interviewed 40 healthcare professionals in maternity services and 40 Comorian women as well, and 15 officers working for different stakeholder organizations. And all the midwives I've interviewed came from metropolitan France. Most of them were young. They had recently graduated from their course, and in a similar fashion also to what has been described regarding midwives in French Guiana, they shared a sense of foreignness, and very few considered settling down. So as a result of all of this, most midwives stayed in Mayotte only for a year or two, and this generated a high turnover on the island. So midwives who conducted what they referred to as the quasi consultations in Mayotte, they were acutely aware of the implications of their medical decisions, and they emphasized the absence of any guidance, medical or institutional, on how to determine whether or not the patient should be delivered a certificate asserting this compatibility with detention. I here would like to quote a conversation between two midwives. "We're supposed to keep them. When they approach the end of a pregnancy, or if they have a pathology for which they are likely to be taken care of specifically in Mayotte, knowing that no one decided that and that we are the one doing this." So I think it echoes very much also what Marie-Anne described earlier about this, what lays on doctor's shoulder in terms of decision making. And then her colleague answers comments, so it's just mentioned like that, and you're on your own. So newer midwives, so to say, because of a high turnover, those who were there only for a couple of months were already considered as those having greater experience. So those who were just coming to Mayotte were familiarized by other colleagues with an informal kind of cutting off date of 32 weeks of pregnancy. More experienced midwives explained to their colleagues that the health state of a pregnant woman should not be deemed compatible with detention from 32 weeks of pregnancy onwards. And conversely, in contrast, it was regarded as compatible before that stage of pregnancy, if there was no other specific medical condition. So here it's explained in that second quote. If everything is fine, we can send them back to the detention center. If there's a problem, in that case, we keep them here. There's no legislation that defines at what week of a pregnancy we're supposed to keep them. When I arrived here, I was told beyond 32 weeks, we keep the patients, but there's no text that defines it clearly. So the midwives I met in Mayotte deplored this unwelcome responsibility and felt uncomfortable with their role in the deportation process, something that usually they had never experienced in their previous professional lives. So one of them lamented it, saying, "It bothers us, this responsibility. It's heavy actually because it's not supposed to be our responsibility." The unease created by the implications of this medical expertise was palpable in the institutional reluctance to accept any kind of regulation. And this was captured in this extract from another conversation with midwives. So they explained, they say it's really up to you. If at 12 weeks you don't want to send her back, well, don't send her back. There's no legislation, there's no protocol. We said, well, it would be good to have a protocol, just so we're covered by the hospital, because at the end of the day, doctors don't want to. They all wash their hands of it, actually. That's not their problem. So it is a bit unclear how this rule of 32 weeks originated, but there certainly was an institutional will to maintain its informal nature. Informality facilitated things for the hospital more than it did for midwives, but the absence of protocol kind of dissolved the question of responsibility. It maintained these practices relatively hidden from view and left midwife also at risk of potential accusations of wrongdoing. So as midwives felt left alone at the forefront of difficult medical decisions, precisely because the decisions were not only medical, the institutional silence attested to the impossibility of care in these circumstances. The consultations were taking place on the premises of a maternity ward and not inside the detention center, but the police accompanied the patient and waited at the door to the consultation room. And this shaped very much the care relationship. Midwives did not hesitate to emphasize the arbitrariness of this informal 32 weeks of pregnancy rule. Another extract from a conversation with them follows here on the slide. Why not 25 weeks? Well, 24, the limit for the fetus viability. Yes, but precisely the main pathologies arrive in the second and third semester. So clearly there existed an internal debate as to the relevance and adequacy of this unofficial 32-week rule. So the rightfulness of this medical decision was discussed, but actually overall few questioned the assumptions that underlined this rationale of a fit for detention type of consultations and the role of the medical assessment in this process. Decisions tended to be discussed and evaluated as to their clinical relevance rather than more broadly also in terms of their ethics. Consultations for these quasi-consultations were short. They were taking place with the police waiting at the door, as I mentioned, and importantly, often with the help of a healthcare system acting as an interpreter. Because there was no direct communication, so all of this produced a lack of also social proximity between the young white metropolitan midwives and the Comorian woman And all of this was also exacerbated by the language barrier and laid the ground for emotional distancing. It's important maybe to mention that in this post-colonial Mahoran context, only a minimal form of communication was possible, kind of navigating between midwives' basic skills in Mahoran and patients' limited knowledge of French. And as a result, many midwives seemed to have withdrawn from engaging much with the patient in this context. One midwife came to the conclusion, I quote her here, I'm really getting into that dynamic to protect myself emotionally. It appeared, so to say, to be easier to make technical decisions to limit interactions with these patients who were actually inclined to plead their cases and to seek an emotional connection with the midwives, because this woman knew very much what was at stake in these consultations. So here to kind of delve into this ethical dilemmas, I have selected another extract from a conversation between midwives, and also to illustrate the socialization into certain type of practices. It's true that humanly at the beginning it's complicated because you want to do things well, to be human and kind, and progressively we'll end up being inhuman, antisocial, and we don't like what we become. Yes, that's a bit like that. Sometimes you set them off a little bit dry, you're going back, that's it, and you say, but what am I? What am I? What am I doing? What are you becoming? But in the end, it's a way to protect yourself as well. And then she mentioned a specific example. The 15-year-old pregnant kid, well, not too pregnant, but still, please, madam, help me stay because all my family here is here. Well, yes, it's heartbreaking, but I have no medical reason to keep you. So how do you want me to do that? So I guess this illustrates also how the midwives needed to shut down some of their emotions to make their practice bearable, and several voiced their feeling of becoming inhumane in this specific context. And I'll share here another, I have many quotes that show how distancing developed by building upon also growing suspicions of patients' claims. And another midwife explained, in terms of relations, it's complicated because at first when I arrived, I struggled with this a lot because I had a lot of empathy. I had a hard time sending them back to the detention center. As time passed by, I took a step back and I told myself that we couldn't keep everyone, so I tried to put some distance. I stay really professional so I don't feel sorry and keep her. It's not easy because often they pretend, they invent some symptoms to be able to stay, they beg us, they lie down on the floor. So it's not easy to manage, but then after a while, with experience, we managed to put a distance and then to explain to the lady, well, listen, at the level of the examination, I have nothing. I can't keep you. So, of course, because of what was at stake for the patients within these interactions, the specific consultations, and because of the power of midwives over their patients' lives beyond medical matters, these situations encompassed more than medical interaction, and the care relation was rendered impossible because these patients were not in a position in which they could trust medical personnel, in view of the high probability that they would be sent back. So there was a lot of suspicion on both sides. And I think that the words used are also quite telling, because another midwife explained, it's true that during interrogation they always find something that's wrong, and it's up to us to weigh things up during examination, and this is very complicated. And the word used in French during the interview was interrogatoire. Interrogatoire is not usually used in the context of care, maybe in relation to the notion of police interrogation. And I think that this chosen vocabulary is kind of symptomatic of the blurring of roles between healthcare professionals and state authorities in this context of border enforcement. Personal stories from family circumstances to survival of shipwrecks were only shared with healthcare assistants when they were willing to listen, because healthcare assistants were usually Mahoran women, so there was not such a strong language barrier. And in one instance, I don't really have time today to go into the experiences, the specific experiences of healthcare assistants, but just really to underline the role lack of shared language. I just want to mention briefly this one instance in which the healthcare assistant who heard the shipwreck story of a Comorian woman who attended such a quasi consultation afterwards did not want to be present when the woman was sent back to the detention on the basis of a medical assessment, because it was too tough for her to see the situation, while this might not have been shared with the midwife because of the language barrier. So I guess that's what I want to highlight today, and also start maybe wrapping up. Overall, the theme that's really at the center of that paper is this question of the normalization of migration control inroads into healthcare, and how also we observe an entanglement between migration control and healthcare services. So it might seem a little bit paradoxical that the community of colleagues, they did provide a space to discuss medical ethics, but actually the outcome was rather a collective reinforcement of the strictest possible approach, rather than one that would be rooted in strong empathy for their patients. And I don't have time today to really draw all the parallels with other studies that exist in the literature, which I do in the paper, but just really maybe to mention one of them, a parallel can be drawn here with the attitude of doctors towards the certificates that serve to sustain an asylum seeker's application, referencing here research by Didier Fassin and Estelle Dalluin, who observed an increasingly distanced assessment of the patient's medical condition over time. And on this point, I here quote another extract from a conversation between two midwives in which they mentioned that. So one is explaining, you learn little by little with the help of your colleagues to remain as objective as possible and to rely only on your clinical and obstetrical examination. And then the other one is addressing a question to her, saying, oh, you're hiding behind your clinical exam. And then saying, I'm teasing you, just teasing. So it was this kind of unease around this quasi-consultations. Because after several months of practice, there is this observation that the initial empathetic stance of many midwives actually tended to be superseded by a dominant norm of distant examination that was imposed at the end of the day by peer pressure, as the midwives narrate themselves. It was not based on any specific protocol or law, it was based by this kind of socialization into this type of practice. And I want also to mention very briefly some data that draws on the hospital archives that I was able to compile during my stay, and that indicated that in 2015, across a total of 238 quasi-consultations, in almost half of these cases, 49%, actually the health situation of a pregnant woman intercepted at sea was assessed as being compatible with detention. And in a similar fashion, 2016, 154 cases of quasi-consultation, and then 57% the women were sent back to detention. So also more than half. So while I wanted to mention these figures, it follows from this that the medical consultation did not protect pregnant women from being deported. So really, just to conclude, I believe that both the many studies that I reference in the paper and this case study that I presented to you today indicate that migration policies are making an increasing number of inroads into healthcare, as also the previous paper has shown, and that further research into the ethics also of medical personnel's involvement in processes of migration control is needed, and also research into migrants' perceptions of these interactions. Thank you very much for your attention, and I look forward to the discussion.
Alors nous avons Nous avons encore une grosse demi-heure pour une discussion. Je vais quand même profiter du privilège d'avoir le micro pour faire quelques références à ces excellentes présentations. Merci beaucoup. Alors, on voit vraiment que le temps sert, surtout entre Marianne et Nina, le temps sert vraiment d'outil de contrôle, migratoire, et que les personnels soignants, à la fin, de manière très involontaire, sont obligés de se positionner par rapport on pourrait même dire qu'ils reproduisent les frontières de par, on a vu le cas de Mayotte absolument incroyable où la décision médicale engage même la décision administrative de détenir les personnes, de les arrêter ou en centre de rétention administrative ou pas. Et sur des critères vraiment tellement aberrants, non ? 31 semaines, on voit qu'une dame a été expulsée, et 32 semaines, elle pourrait être, c'est une sorte de critère informel. Alors je voulais tout simplement vous demander, dans quelle mesure s'agit-il de stratégies volontaires ou du moins conscientes de la part des États, ou comme on l'a vu dans les présentations du panel antérieur, c'est une sorte de résultat diffus, une conséquence de politique de bureau mal pensée, pour ainsi dire. Et pour Julia, une question rapide. Alors justement, cette question des temporalités et du temps, déjà, comment ces femmes s'approchent-elles de l'association ? À quel moment de leur parcours, surtout pour les femmes migrantes, à quel moment de leur parcours migratoire ? Mais toutes ces activités prennent du temps, non ? On voit qu'il y a des activités de nutrition psychologique, il y a des ateliers, des danses, etc. Et comment est-ce qu'elles font pour combiner cela avec leurs activités quotidiennes, puisque j'imagine que ce sont des femmes qui travaillent beaucoup, qui doivent combiner même plusieurs emplois. Donc comment est-ce qu'elles peuvent gérer, et j'imagine qu'il y a aussi des questions de rupture, des abandons temporels, etc. Voilà, donc pour commencer, et puis par la suite, avec plaisir, on passera le micro au public.
Do you hear me now? Yes. Yes. Are the policies deliberately or just poorly designed? Well, Norwegian. I think well, I think they are deliberate. In my research, I've sort of used more the Foucauldian approach of seeing it as a strategy of government, which you can detect through the effects that it's deliberate but non-subjective. It's a result of several acts, but you can also see it quite obviously stated by governments as well. That their intentions there is an intention of making life difficult for irregular migrants. That is quite explicit, and healthcare is becoming part of it. But they did state that healthcare that cannot wait was meant to expand access to healthcare. That is explicit in the policies, but in practice it has not, because it is largely interpreted as emergency care in Norway. So it hasn't expanded. And this has been raised to the government by the healthcare clinics, and I've also been part of it, and it doesn't make an impression. So, yeah, I think they live well with it being difficult. What I was perhaps surprised more by was how healthcare providers largely ended up accepting this. Because I started my research in 2011 when this law was implemented, or this regulation, it was not a law. And I expected a lot of resistance. And there were some. I mean, you do have the volunteer-run health clinics, and I met some. But largely, a lot of the healthcare providers that I encountered by following irregular migrants did sort of try to do this. They tried to do this evaluation of will this person be deported? Should I start treatment? And I think precisely as also Nina said, there was this normalization of migration control within the healthcare system that did actually surprise me. And it has, over the years, become even more normalized. And we see that when I started, there were still several of the undocumented migrants that I followed were able to access healthcare and did not receive bills. But we see a gradually hardening of access over the years since I started in 2011. Because the system has become better of detecting undocumented migrants, and doctors have been used to it. One last thing, it became a long answer to this, but also I think ignorance play a role here, and then I will say deliberate ignorance. In the previous panel, it was mentioned in the presentation that that often it was the frontline persons that made the decision of stopping migrants. And I could also see that in my research. And a lot of the healthcare providers would say, or doctors would say, I don't care, I will treat everyone the same way. But they were very comfortable not knowing, and it also had consequences not knowing. Because when people live in a irregular state, their situation is difficult. In one case, a person coming to the emergency care were treated as any other person, but she did not have access to a general practitioner that would follow up her treatment. And the next time she came to the emergency care center, her situation had become fatal because she had been treated as any other patient, but she didn't have the same support and care system around her. So there is a sort of ignorance that is comfortable for the doctors, but which is quite problematic as well within the system, I would say. Yeah.
Yes, thank you for the question, and I think that I mean there are many things that in the context of Mayotte do look a little bit surreal. To say this fact that you have 1/10 of the population that's going to be deported every year, and whether then it's deliberate ignorance or just kind of a deterrence package to that builds on this idea that the more you have this kind of exclusionary politics, the less people you will have to come. In a way, that's not in question, but when you do research, when you can provide very specific answers, and doing research with Comorian women, it appeared very clearly that they have not arrived yesterday, as is often the dominant media coverage of these issues, but most of them have been living there for many years, and they just become caught up in this in this politics of irregularization. I would say it's very difficult for them to become regularized because you have additional criteria, and notably financial criteria, and because of the socioeconomic disadvantages that characterize Mayotte, then it's harder for them. But also you also have dysfunctioning local administration, like the department for the service for where you should apply for regularization was closed for several months, for example. So there, like when you just try to look a little bit, not even very far beyond the surface, you just really can see how obtaining regularization is very difficult, and in relation more specifically to the role of healthcare professionals, I think that's what struck me, and the type of question I really wanted to delve into was exactly what you said, what you described, Mary-Anne, saying I would also expect more resistance, and I also need to mention that actually in their daily work, these midwives, they attended many undocumented women, because most women or a very high share of women on the island are undocumented, so they would provide care to many undocumented women. But when they would receive those who were intercepted at sea by the police, then that was a different care setting, in the sense that in that case you would have a policeman at the door, which you wouldn't have for just an undocumented woman coming for regular consultation. And it was a bit striking to me to observe how fast the socialization into migration control would go, and I guess what I was also trying in the paper to point at is how in a way this type of consultations are then instrumentalized. So you have this kind of biopolitical facade, also drawing on Foucauldian studies, of saying, okay, we're going to make sure that we ensure that, you know, kind of a minimal survival and that the body can survive. But actually, how this involvement of healthcare professionals is used to produce necropolitics and exposing people to death. Because once you get the medical certificate that attests that, okay, your health is compatible with detention, and then you spend a couple of hours in the detention center, actually you are deported a few hours later, and it is very probable that you're gonna attempt the crossing again, and attempting the crossing again means that you are exposed to a shipwreck and that you are exposed to death. So what I've also kind of maybe struggled to make sense of was how involvement of healthcare professionals sadly also kind of is caught up in necropolitics.
Alors, comment sont orientées les femmes à l'association? Elles sont orientées majoritairement par les services, par les médecins, les hospitaliers, les services, d'autres associations, etc. Ce qui, je pense, explique le fait qu'elles ont toute la sécurité sociale. Et au niveau de leur migration, c'est assez varié. Il y en a qui sont arrivés depuis 1 an, d'autres depuis 40 ans. Donc, c'est des profils assez différents. Comment est-ce qu'elles ont le temps de venir? C'est ce qu'on voit justement, c'est que celles qui courent après les petits boulots, elles n'ont pas le temps de venir. C'est pas leur priorité de s'occuper de leur santé, de faire du sport et voilà, d'apprendre sur comment manger équilibré, et on peut le comprendre. Mais là où justement l'accompagnement a réussi à transformer l'essai, c'est justement quand ces femmes-là intègrent dans leur quotidien un passage au centre ou bien dans leur activité, enfin dans leur vie personnelle, cette hygiène de vie qu'elles adoptent. Mais sinon, c'est vrai que la majorité des femmes qui viennent très régulièrement, c'est des femmes très isolées, qui vivent seules, qui n'ont pas de famille à proximité, et qui en fait viennent surtout pour retrouver leur père.